All right, good morning, guys. It is Wednesday, October 28th, 2020. We are continuing the last day of lecture for RT 210D, which is Pulmonary Mechanics. Next unit will be ABGs, which is gas physics. Acid-base chemistry or blood chemistry, which is can be a doozy if you don't take it serious. Now, this is ABGs, arterial blood gases. And what you'll be doing, having to stick an artery. Not only do you have to know how to do it, but when you run it, you got to know what to do with those results. Okay, and those results from the ABG will be indicative of the pulmonary mechanics that your patient is exhibiting. How are they ventilating? What is their ventilations? What is their dead space ventilation? Are they oxygenating? All those things will be in the ABG. And they will depend solely on the CO2 as far as what the pH is doing. And the pH of the system of the blood is very, very acidic. It's because there's a whole lot of CO2, because we said CO2 is a what? Acid, right? So if there's a whole lot of it in there, then it can cause the pH to be very acidic. And then there's also a metabolic situation in your bicarb. And so those are some things that we are going to have to understand when we get to acid-base chemistry. But they solely pertain to what you're doing now, which is pulmonary mechanics. So please do not remember this for the test and then move on to the next section. You will not be able to pass the final or the orals if you do not go back and study all of the material. They all link together like a chain. Every unit in 210 is a chain, and you may be asked any link of that chain at any time, especially if you've already covered it. All right? All right. So this is going to be the last day. We're going to finish out the lecture. We got like a page or two of lecture left. We're going to work on some class work, maybe do some review type questions, and test will be tomorrow. So then after that, we're going to move right along into the next unit. Okay? All right. Let me share my screen with the lesson plan to finish up. All right. So even though we talked about a lot of this, I'm going through the actual lesson plan, which we're now at gas exchange units. Talked about yesterday the different types of units. We got the normal unit, dead space unit, shunt unit, and the silent unit. Remember, a normal unit when you have a good relationship between perfusion and ventilation. Remember, we said the VQ is ventilation to perfusion. Ventilation to perfusion ratio, right? We should have about 4 liters per minute alveolar minute ventilation to 5 liters per minute of cardiac output, right? That's about normal. But when we have not normal, we have a VQ mismatch, right? Something's going on. Then that can tell us what may be going on in the alveoli. Okay, so we have a dead space unit. It's when the alveoli is fully perfused. I mean, the alveoli is fully ventilated, right? But for some reason, there's no perfusion. The capillary or the blood flow is not there. So that good old ventilation, and I use that type of English for a reason, for emphasis, that good old ventilation is wasted, okay? Wide open. We said if the store is wide open and you are the owner of the store, you went and bought all this product and people are supposed to come and get it, then if they don't come, you waste it. It's wasted product, right? If the alveoli is wide open, fully ventilated, full of oxygen, but there's no blood to pick it up, that's dead space. It's just dead space, just like it is in the conductive airways. There's no gas exchange. If that blood flow is not there, then there can be no gas exchange. And anywhere that there is no gas exchange, then that's dead space, right? That's gas is there, but there's no exchange. That's dead or wasted gas, okay? Then we have the shunt unit. Now this is when you have perfusion, but there is no ventilation. So on the other end of the coin, if the patrons come to your store and they're all lined up at the door, but the door is shut. Shunt, shut, shunt, shut. Okay? The alveoli is not ventilated, right? But the blood is there. That's a shunt. So what happens is the blood returns to the heart from the body, deoxygenated and used up, right? It enters into the heart via the superior and inferior vena cava. Then it dumps into the right atrium through the tricuspid valve into the right ventricle, right? And then through the pulmonary valve and into the pulmonary artery and then into the lungs, right? That's all pulmonary circulation. The pulmonary circulation, because the heart is circulating that side to the lungs. The right side of the heart is pulmonary, deoxygenated blood flow to the lungs from the heart. Then it comes back to the heart on the left side, right? But if that good old blood went to the lungs and knocked on the door of the alveoli and they were closed, then it still got to come back to the heart, but it's going to come back to the heart empty-handed. And that means it's going to come back with no oxygen. It didn't pick up the oxygen and it couldn't release the CO2. So it comes back deoxygenated. That's a right to left shunt. It went from the right side of the heart back to the left side of the heart without picking up oxygen. So that is a shunt unit. Okay. Now it says perfusion without or in excess of. Now, to have a shunt, you don't have to have no ventilation. It's just said if the perfusion is either no ventilation or in excess of. Like we started to play with the numbers. If we said that we had a VQ mismatch of 0 to 5, that would be a shunt, right? We got perfusion, but we don't have any ventilation. Well, just like 0 to 5 would be a shunt, so would 2 to 5, right? Or 1 to 5, because it should be 4 to 5, right? So it's saying it can be in excess of. Don't necessarily have to be no ventilation at all. It just means if the perfusion is way in excess of the ventilation, that's a shunt. Same thing as far as dead space. If we have a VQ mismatch of 4 to 0, that would be a dead space unit, right? We have all the ventilation, but no perfusion. But it also could be 4 to 1 or 4 to 2 of cardiac output, right? It's still a dead space unit because the ventilation is in excess of way more than it should be than ventilation. All right. So the proper definition is dead space is ventilation without or in excess of perfusion. Shunt is perfusion without or in excess of ventilation. And then the silent unit is simply no perfusion and no ventilation. All right. Then we go into the regional differences. We said we'd talk about regional differences today. And this has got to do with the area of the lungs, okay? The area of the lungs that we would experience this ventilation to perfusion situations, okay? So, number one, there's more ventilation to the bases of the lungs than it is at the apices. And you would think since air rises that it will be more ventilation going on at the top, but that's not true. More ventilation is at the bases of the lung than it is at the apices of the lungs. Okay, so this is the base of the lungs here. This is the base, the bottom. Apices at the top. What they're saying is you get more ventilation, more gas exchange happens at the base of the lungs than it does at the apices. Well, how much more, Mr. McCarthy? Well, I'm about to show you. 4 times more ventilation to the bases than the apices. There's 4 times more ventilation going on at the base of the lung than it is at the apices. Now, why is that? Well, due to gravity's effect on pleural pressures And then on inspiration, the transpulmonary pressure is greater at the bases. So it's sucking in more air at the bottom because remember we talked about the pressure gradient? We talked about pressure, and we said that inside the lungs, it is lower or more negative than it is outside. So air has to go into the mouth, right? Well, not only that, but at the base of the lungs, it's even more negative than the top of the lungs. So that gas is still flowing down, finding the path of least resistance. So it's going to the lower side, okay? So that's why when you inspire, we have more ventilation at the bases than we do at the apices. And not only that, it's 4 times more, okay? Now, let's look at perfusion. There's also more perfusion to the bases, right? There's also more blood flow to the bases, and this is mainly due to what? Gravity, because blood is, it's a liquid, so if you're sitting upright, it's going to drain down to the bottom just because of gravity. So that's the main reason. And how much more perfusion is at the base than at the top? 20 times. There's 20 times more perfusion to the bases than it is at the top of the lungs, which is the apices. Okay, so make sure you know that because those will be questions. 4 times is more ventilation at the bases than the apices, and there's 20 times more perfusion at the bases than at the apices. All right, ventilation perfusion ratio. It's the last little bit here. We talked about it yesterday. VQ is ventilation to perfusion. We said that you should have 4 liters of alveolar minute volume to 5 liters of cardiac output. Four liters of alveolar minute volume to 5 liters of cardiac output. So for every 4 liters of alveolar minute ventilation, there should be 5 liters of blood being pumped from that left side. So every minute, 5 liters of blood leaves the left side of the heart to go to the body. 5 liters a minute. All right, so let's look at this water bottle. I like to use my water bottles as a reference guide to amounts. Is this 1 liter? I'm not sure. This is 16.9 fluid ounces or a pint, right? Or 500 mLs. This is 500 mL. So 2 of these is 1 liter, okay? So let me get to it. This is how much blood is being pumped from your left ventricle to your body every minute, okay? Now, as a matter of fact, it's more than this. This is how much? Anybody here can tell me how many liters is this? This is half a liter, this is half a liter. So how many liters is this together?
1.
1. So if this is 1 liter, how many liters did we say is actually going through your heart per minute?
5.
5. So 10 of these, if this is a half a liter, this is 1 liter, and there's 5 liters, 10 of these is leaving your heart from the left side every minute. In a minute's time, your heart has pumped 10 of these worth of blood. 5 liters per minute. 5 liters per minute. 10 of these. Or 2 liters and 2 of these, right? That's a lot of blood. That's a lot of blood. And that's a lot of work for the heart. That's a lot of work for the lungs to be able to process that amount of blood, right? Because not only is it coming from the heart, but if it's that much leaving the heart, there must be that much coming to the heart. And so when all that blood is coming back to the heart, to the lungs have to gas exchange, and do all the magic and then send it on. With every beat of your heart, that much blood, that's a lot. That's a lot of blood. So imagine if your left ventricle is only fibrillating, then that blood is now sitting still. And that's why you die. That's cardiac standstill. You must defib, shock that heart into going back to what it's supposed to be doing. Okay, that's a lot of blood. And so 4 liters of alveolar minute ventilation has to process that much blood every minute. And if you're healthy and have some regular lungs, then that should be fine. You do that without batting an eye. You do that without batting an eye. So that is the normal VQ ratio. Okay, 4 to 5. It's also known as 0.8, just like respiratory quotient is 0.8. But that's a lot of blood, and that's a lot of jobs. So when we have that kind of blood, and that blood is down to like just maybe a half a liter, right, or just 1 liter, now you got all of that alveolar minute ventilation, right, but just a little bit of blood, right? That will be a dead space, right? Or if we have all of that blood coming to the lungs, but only a little bit of it is being gas exchanged, that will be a shunt, right? The blood is there, but the ventilation is not. So you see how it's a perfect system that must be maintained by the heart and lungs to keep you oxygenated, to keep your heart rate down, to keep your respiratory rate down, to keep you feeling like you can breathe. Because once that VQ mismatch gets off tilter and gets out of whack, then you start saying, hey, I can't breathe. I'm short of breath, right? You're not short of breath. You're just not oxygenating, and your body is going into panic mode. Then the heart said, well, let me beat harder and let me beat faster. And the lungs say, well, let me breathe deeper or faster, trying to do the job that you've been doing before you started smoking, before you started whatever you're doing that is damaging your lungs. Okay? All right. So let me go over to the PowerPoint that shows those alveolar units. I told you to look at that last night. So let's see here. Lung units. I could have swore I had something on here for volume stop. That's not what I want. Here we go. Classifications and alveolar units PowerPoint. All right, so let me share my screen. All right, so this was again was I told you to look at, but this just right here, we already talked about the dead space. Let's look at it. Let me see here. Okay, that's minute ventilation. We got that. Dead space. We have 4 types: anatomical, alveolar. So anatomical is the dead space that fills the conductive airways. Alveolar dead space is alveoli that are not perfused. So look right here. This right here is some alveoli. On one side, this alveoli is full of ventilation, right? And it's perfused well. You got the deoxygenated blood, then gets the oxygen and comes back oxygenated. But on this side, you have a ventilated alveoli, but no blood flow. See that? There's no blood flow. So in this case, this would be a dead space unit. Now, we talked about we have anatomical dead space, or the conducting airways. Then we have alveolar dead spaces when we have ventilation but no blood flow. And then mechanical. This will be the tubing, right? We add extra artificial airway or extra tubing on the circuit. That adds more dead space, which is called mechanical dead space, right? Alveolar ventilation, just showing you how that happens. Alveolar minute ventilation is tidal volume minus dead space times frequency. We went over those. I just want to go over trying to find we did the hyperventilations, and then let me see where the perfusion, ventilation, perfusion, respiratory quotient. Here go those units here. Normal unit, dead space unit, shunt unit, silent unit. And here's some pictures here. All right. A, B, C, D. A is a normal ratio. Look at this. You got air in the alveolus. You have capillary blood flow. That's normal. This is a normal unit, right? Good volume and good blood flow. But look at B. B is a shunt. Look at this alveoli. For some reason, there's a blockage there. It makes that alveoli collapse. This alveoli has collapsed, but the blood flow is good. Look at that blood flow. You got wonderful blood flow, but no ventilation. That is a shunt. All right. C is dead space. You got the alveoli is fully ventilated, but look, there's blockage in the blood flow, so there's no blood flow. See, showing a blockage there. So look at that blood flow. No or very little, right? So that all this gas is being wasted because there's nothing there to pick it up. And then finally, the silent unit is where we have a collapsed alveoli and no blood flow. So that's what's happening in 300 to 600 million alveoli in your body. All of those have to have their own blood supply. That's a very amazing aspect of your body. The heart and lungs are amazing. All right, I just wanted to show you a picture of that. These are the regional differences we already talked about. Now let's talk about the 4 types of shunt. You got shunts that we have 4 types of. Let me see if I have it in the I should have this in the hold on. Let me stop that share and go back to the lesson plan. I don't really like those colors. Where's my? All right, here we go. So the shunting, we said, of course, we already know that shunting is unoxygenated blood entering the left side of the heart, right? If blood gets to the left and it's not oxygenated, then there was a shunt because the blood was there, but there was no ventilation to give it oxygen, okay? So in a nutshell, unoxygenated blood that gets to the left side of the heart is a shunt, okay? It should not be unoxygenated. By the time it gets to the left side, it should be fully oxygenated. But if it doesn't pick it up in the lungs, then that's a shunt. Okay, it got there, but the alveoli was closed. So what are the types of shunt? We have an anatomical shunt. Anatomical shunt. And this is something that you can't help, right? It's just anatomical. And this is the types. The anatomical shunt is because of this. Now, it's normally about 2 to 5% of the cardiac output is an anatomical shunt. You just can't help it, right? Nothing you can do about this. And why? And the reason why is because you have bronchial veins. We have some bronchial veins that drain bronchial circulation, right? And you know, veins are deoxygenated, and we have some bronchial veins that kind of drain into the circulation, okay? Just automatic, the small amounts. Bronchial veins will drain into the bronchial circulation. We have pleural veins that drain pleural circulation. And we have thespian veins that drains heart circulation. So because of bronchial veins, pleural veins, and thespian veins, that constitutes our anatomical shunt. You just can't help it. Some of that deoxygenated blood just leaks into the circulation. It just by default, that's what happens. That's an anatomical shunt. Now, remember that the anatomical shunt makes up about 2 to 5% of the total cardiac output. Okay, we said cardiac output should be 5 liters per minute, but 2 to 5% of that blood is anatomically shunted blood. Okay, the next type of shunt will be an absolute capillary shunt. This is also known as a true shunt. This is when there is alveoli that's perfused but not ventilated at all. Remember, we said we have some shunts that sometimes there's ventilation. I mean, there's perfusion, but there's maybe a little bit of ventilation, right? Just a little mismatch can still be called a shunt. We got perfusion, but not enough ventilation, so we can call it a shunt. But an absolute smack in your face true shunt is when you have perfusion, but no ventilation at all, okay? That is a true shunt, right? Also known as an absolute capillary shunt. Absolute capillary shunt is when it's no nonsense, smack you in your face, perfusion with no ventilation, okay? This type of shunt is refractory to oxygen therapy. Now, I want somebody to tell me in the chat, what does refractory mean? Find out what refractory means and let me know in the chat, because it's very important. This is a very important term that you're going to have to deal with as well when we get into oxygen therapy. But what does it mean that the true shunt is refractory to oxygen therapy? I'll give you a moment to find that. I'm gonna pause the video while you guys find that answer. Going back, if I'm used to opening up like this, open up, close, open up, close, and the blood is going by, picking up all this good old oxygen. Alveoli is opening up, opening up, closing. Well, what can cause shunts is, the first thing is a decrease in ventilation. So now if I was opening and closing, and now I'm just opening, closing, that's a decrease in ventilation, and I'm not sucking in as much oxygen. If I don't get as much oxygen in the alveoli, it can't get to the what? Bloodstream. So that can be a cause of the shunt, simply a decrease in ventilation. Okay. Number two, an increase in perfusion. What if my cardiac output shot up? That still can be a shunt, because say I had about 3 liters per minute of ventilation and 5 of cardiac output, right? So I'm relatively okay, or 4 to 5. I'm okay. That's regular. But what if my cardiac output all of a sudden increases to 8 or 9? For some reason, I'm pumping 8 or 9 liters of blood, and I still only have 4 liters of alveolar minute ventilation. That's still considered a shunt. That can cause a shunt, because I have perfusion in excess of ventilation. Should be 4 to 5. But if I have 4 to 8, that's too much perfusion, right? That's too much. So my perfusion now is in excess of ventilation, so that can cause a shunt. Now, a couple minutes ago, I forgot to push record. So let me go back to this little part right here, just for the ones I didn't record for. We have the anatomical shunt, absolute capillary shunt, relative capillary shunt, and physiological shunt. These are we're getting into the details of the shunt. And I had just told the class that a true shunt is when you have perfusion, but absolutely no ventilation at all. The relative capillary shunt is when you have perfusion and not enough ventilation. It's there, but it's not what it should be. So there's a mismatch, right? The 4 to 5 is not right. It may be 4 to 3. I mean, it may be 2 to 5 or 1 to 5, something like that. The ventilation is there, but not where it should be, because now perfusion is in excess of ventilation. That's a shunt, right? And then you have the physiological shunt, and that's just a sum of all of them. Anatomical plus absolute plus relative equals physiological shunt, okay? And then we came down to say, what are the causes? Decrease in ventilation. A decrease in ventilation can cause a shunt. An increase in perfusion. If my perfusion shoots up past 5, it should be 5 liters per minute, but if I'm pushing out 8 liters per minute and I still only have 4 liters of alveolar minute ventilation, then now my perfusion is in excess of ventilation, and that's a shunt. Okay? And here's the dead space. We already talked about this part. I told you the dead space, you have anatomical, which we know is in the conducting airways. Alveolar is the alveoli that are decreased perfusion, right? You got air but no blood. That's alveolar dead space. Physiological dead space would be a sum of anatomical and alveolar. And then finally, we said that mechanical dead space is when we add more circuit to the patient's breathing system, right? you have the breathing system, but now I want to put grandma a little farther away. She likes to be, say I got a grandmother on a ventilator at home, right? And she has a home ventilator with tubing, okay? Well, grandma don't like to be in the back room no more. She wants to be put up in the front where she can watch her stories on the big screen, okay? So in order to move her, but the machine, the ventilator has to stay where it is because it's plugged up. That's the best electricity in the house and this, that, and whatever, the emergency plugs and all of that. So we can't move the machine, but we're going to move mom. Well, if we want to move mom, then we have to add more tubing to her line so she can fit in the other room, right? It'll reach to the other room so she can watch guiding light on big screen, okay? So now we have whatever we add to her circuit, we just increased her mechanical dead space, okay? We just added more tubing to her circuit, which added more dead space. And I told you, for every link of a circuit is 50 cc's of dead space, okay? Every link. See these links? From smooth to smooth, this is a 6-inch link. 6-inch corrugated tubing. Every 6 inches, there's a smooth place for you to cut. This is where you would cut. You don't ever want to cut in here. You'll never be able to get that on anything. You have to cut on the smooth surface so it'll fit up on whatever you're trying to hook it up to. But for every 6 inches, for every link, that's 50 more cc's of dead space. Okay? Just FYI, every link is 50 cc's of dead space. So when I add a whole lot of this to get grandma into the other room, now I'm adding all this dead space. Look, how much dead space is in just this? Well, we have 50, 100, 150, 200, 250. This is 250 mLs of dead space, just this. Okay, 250 cc's. Remember, the average adult human only has 150 cc's of dead space. The connective tissue, the connective airways is only 150 cc's of dead space. This is more than your human body. This is more dead space than 2 people, almost 2 people. So, and this is nothing. This ain't gonna get grandma to the other room, all right? So you have to be mindful of that when we're talking about adding more circuit to somebody's breathing system, because we're adding a whole lot more dead space, a lot of gas that's not participating in gas exchange, okay? All right. Let's get to a stopping point and take a break. Let me see where we're going to be. All right. So, yeah, those are the 4 types of dead space. And then the causes. I think that, yeah, this is it. This is it. We're going to take a break. The causes of dead space will be an increase in ventilation, right? What if I'm breathing like this? I'm breathing like this, like that. In and out, in and out, right? 4 liters per minute, no problem. My cardiac output is 5 liters per minute, no problem. Perfect. VQ is perfect, right? Normal unit. But then all of a sudden I start breathing like this. In and out, in and out. I've increased my ventilation, but my cardiac output is still 5. So now I got like 10 or 12 liters per minute of alveolar minute ventilation, but still 5 of cardiac output. That is dead space, right? Dead space is when you have ventilation without or in excess of perfusion. So it was 45, but then I increased and I started breathing so much, huffing and puffing. Now I have my ventilation is in excess of my perfusion, and that is classic dead space. All right, so I'm gonna pause the recording right here. I want you guys to take. It's 9 o'clock. We're back from break. I'm gonna pull up something. I'm just another little shot that I'll email this one to y'all, or I might put it in the the module. But this here is a picture of the alveolar units. Okay, so I'll make sure you get a copy of this. This is the normal unit here, where you have the ventilation and perfusion. Dead space unit, when you have ventilation and little or no perfusion, right? And then you have the shunt unit when you have little to no ventilation, but plenty of perfusion. And then the silent unit would be no ventilation and no perfusion, okay? Those are the 4 units. alveolar units. Okay, I just wanted to show that to you right quick. Now I'll put it in the module or email the announcement or something like that where you can look at it. All right. So this is what we're doing now. Now we're going to work on a few questions. I want everybody on here to log into this poll right here. It's a question should be popped up on your screen. It's a like a polling question. What type of alveolar unit has zero perfusion and zero ventilation? I want you to put your answer. I got 1 response, 2 response, 3 response. 2 more people I need to respond for it. Good. That's a silent unit. Silent unit. Good job. All right. All right. All right. Answer these questions. Number 1 says an increase in dead space. An increase in dead space will result in a decrease of what? Answer number 1 first, then we'll go on to number 2. And it doesn't tell me who answered what. It just tells me that I have 5 people, and 5 people what percent answered what. So I want you to tell me. An increase in dead space. If I increase my dead space, I'm going to decrease my what?
Can you see it even if we don't submit it?
No, you got to submit your answer. Oh, you're talking about because you didn't do number 2 yet? It's making you answer all of them?
Yeah.
Oh, okay. So well, everybody did number 1. Okay, now let's look at number 2. Whose law states that if you decrease the diameter by 1/2, then you increase the resistance by 16 times? Who said that? Make your answers, and then you can do number 3 as well. Number 2 says, whose law states that if you decrease the diameter by 1/2, then you'll increase the resistance by 16 times? And then number 3 says the term that means wasted ventilation is what? And number 4, a Reynolds number of 2,000 to 4,000 is an indicator of which type of flow? Okay. All right, so let's look at it. Number 1, an increase in dead space will result in a decrease of alveolar minute ventilation. So 3 people got that one right. Some say compliance is not compliance, and it's not minute ventilation. Increase in dead space will, if you're talking about minute ventilation, you're going to increase the minute ventilation because you're adding more more dead space, more volume, period. Okay, but only time we make a distinction is when we're talking about alveolar minute ventilation. So if I increase my dead space, that's going to make my alveolar minute ventilation go down. So make sure you get that. If I increase my dead space, I'm going to decrease my alveolar minute ventilation. If I decrease my dead space, then I'm going to increase my alveolar ventilation. Okay. Number 2, whose law states that if you decrease the diameter by 1/2, then you increase the resistance by 16 times. That is Poiseuille. Good. All 5 of y'all got that. Number 3, the term that means wasted ventilation is dead space. Everybody got that. And number 4, a Reynolds number of 2,000 to 4,000 is mixed flow. Mixed flow. So less than 2,000 is laminar or smooth, right? Greater than 4,000 is turbulent. 2,000 to 4,000 is considered to be a mixed flow. All right, good job. Let's see what else I got. All right, so I got some more as we go on. I have some more in here, but those are for later. All right. Okay, we're gonna work on a few questions, classwork questions. All right, I want everybody to try your best to work these without any help. Try not to use any help, because I'm not going to stay on them long. I'm going to go over them quickly. I want to see if you need to see how much you have grasped in your study by now without looking, because the test is tomorrow. Number 1, the maximum amount of air that can be breathed in and out in one breath. What is that called? Don't answer it out loud, but write your answer. And I'm going to ask a few people, what did you get for number 1? What did you get for number 2? Stuff like that. And you kind of test yourself. The maximum amount of air that can be breathed in and the maximum amount that can breathe out. What is that called? You got to look very close attention to the wording. So you can put your answer in the chat for number 1. Put your answer privately to me. Privately to me. Good, Barbara. Good, Alicia. Miss Thomas and Miss Rose need to look at it again. Good, Caleb. Maximum in and maximum out. Everything that you can do. All you can breathe in and all you can breathe out. Good, Miss Rose. There you go. Vital capacity, the maximum. See, that's why you have to really look at the wording. The maximum amount of air that can be inhaled and out is vital capacity. Tidal volume would be normal gas that's in and out. That's normal gas that's moved during inhalation and out exhalation, or quiet inhalation and quiet, or normal in and normal out, right? But the maximum in and maximum out would be vital capacity. Number 2, the exchange of oxygen and carbon dioxide between the alveoli and capillaries is called what? Put that in the chat. What is that called? Gas exchange and the oxygen from the alveoli and outside air. What is that? Good, good. Good. External respiration. External respiration. Number 3, the amount of air moved in and out of the lungs during normal, quiet breathing is called what? Good, Miss Scott. Good, Miss Thomas. Look at it again, Miss Tabor. Miss Rose, look at it again. Good, Kayla. The amount of air. Look at the question, guys. The amount of air moved in and out of the lungs during normal, quiet breathing. That is tidal volume. Tidal volume. Okay? Number 4. Which volume is not included in the vital capacity? Which one of these volumes is not included in the vital capacity? Good, Scott. Good, Kayla. Good, Miss Thomas. Look at it again, Miss Rose. Which one is not included? Remember what vital capacity is. Good, Miss Tabor. Vital capacity is everything that you can do. So which one of those volumes is something that you can't do? Good. Residual volume. The RV or reserve volume, residual volume, those are the volume. That is the volume that's not included in vital capacity. All right. Number 5, the exchange of oxygen and carbon dioxide between the capillary and the tissues is called what? Good, Miss Rose. Good. Kayla, look at it again. Internal respiration. Good. Internal respiration. All right, number 6. In terms of other volumes and capacities, how can vital capacity be defined? Which one of those define vital capacity? Good, Kayla. Good, Miss Tabor. Miss Scott, look at it again. That answer should be B as in boy. Tidal volume plus inspiratory reserve volume plus expiratory reserve volume. That's everything you can do, guys. You see how it switches it up? But you got to know that spirogram. That's why you have to be able to draw it and study it. Everything you can do. Tidal volume is normal in, normal out. Inspiratory reserve volume is all that I can breathe in and then push out, push out, push out, push out. That's my expiratory reserve volume. All 3 of those together is my vital capacity. Okay, it wouldn't be TLC minus the ERV. It wouldn't be inspiratory capacity plus RV. That they don't go together like that. Okay, and ERV and RV is FRC. So that's not, only one for vital capacity would be B as in boy. B as in boy. Number 7, what is the correct formula to calculate alveolar minute ventilation of a spontaneously breathing subject? Alveolar minute ventilation. Alveolar minute ventilation. Which one of those formulas is right? Tabor, look at it again. Good, Kayla, that's right. think you said the same thing, Miss Scott, unless that was your last answer. Ms. Tabor, still need to look at it again. Alveolar minute ventilation, Miss Rose, that's good. Alveolar minute ventilation is frequency times tidal volume minus dead space. Tidal volume minus dead space times the frequency. Just because the F is on the other side does not make it wrong. It's still mathematically correct. Okay. Number 8. Which of the following volumes or capacities cannot be measured by simple spirometry? Good, Kayla. Good, good, everybody. C, 1 and 3. Simple spirometry, guys, is like something I could do at the bedside. In order to measure the residual volume, you have to be in a PFT study and sitting in the body box. So anything that's got to do with RV cannot be done at the bedside. So the only choices with this will be number 1, which is the FRC, because the RV is part of the FRC, right? And then RV. So 1 and 3. So I couldn't test those two on simple spirometry. Good. All right, number 9. Which of the following is true? Which one of these following statements is true? Good, Kayla. Good, Miss Rose. Good, Miss Scott. Miss Thomas, good. All right, it's B. We just had that one earlier. Vital capacity is IRV plus VT plus ERV. It's B. Should be B, Miss Tabor. All right, look at number 10. The formula for compliance. Which one of those is right? Good, Miss Tabor. Good, Miss Thomas. Miss Rose. Should be C. Change in volume over change in pressure. Volume over pressure. That's compliance. All right, number 11. After a resting expiration, air still remains in the lungs. What is that volume called? Good, I flew on that one. RV, residual volume or reserve volume. All right, here's a calculation. A patient has a tidal volume of 625 mLs and a dead space of 275 mLs and is breathing at a frequency of 16 times per minute. What is his alveolar minute ventilation? Try not to use your stuff if you can, because you won't be able to use it tomorrow. What you got? Good, Miss Scott. Good, Miss Thomas. Good, Miss Rose. Good, Kayla. Now, Miss Tabor. Look at it again, Miss Tabor. All right. Alveolar ventilation is frequency times tidal volume minus dead space. In this case, we have a tidal volume of 625 and a dead space of 275. So you got to do 625 minus 275 gives you 350. Then you take that 350 times 16, his frequency is 16, and you get 5,600. If you did 0.350 times 16, you would have got 5.6 liters. So it's either 5.6 liters or 5,600 milliliters. That's how you do it. All right. 13. Which ventilation is insufficient to meet metabolic needs? Which one of those is insufficient? Good, Miss Rose. Kayla, look at it again. Miss Scott, look at it again. Good, Barbara. Miss Thomas, look at it again. Insufficient to meet metabolic needs means I'm not ventilating good enough. My metabolic needs are to get rid of this CO2, and if I'm not getting rid of it, what's that called? Good, Kayla. That is hypoventilation. Hypoventilation, guys. When I'm not breathing, my metabolic needs are to get rid of CO2 because CO2 is a byproduct of metabolism. So when I'm metabolizing, I need to get rid of CO2. And so which one of those ventilation is not getting enough, getting enough CO2 off? That would be hypoventilation. If I'm hypoventilating, I'm not getting the CO2 off like my body needs. That's insufficient. Insufficient. Okay? Hypopnea is not even a word. All right? So hypoventilation is the term you're looking for there, guys. When I'm not ventilating enough. Okay? Insufficient. I'm not blowing off enough. The whole name of the game is to get rid of CO2. All right, number 14. What amount of gas can be inhaled over and above that which is normally inhaled during quiet breathing? So after my quiet inhale, I suck in as much as I can after that. What is that volume called? Good, Miss Thomas, Kayla. Good, Miss Scott. Miss Rose, did you answer this one yet? Look at it again, Miss Tabor.
Yes, I did.
Okay, well, good. Because y'all numbers so fast, I don't know if that was the last choice or not. That one should be inspiratory reserve volume, C. Tidal volume is normal in, normal out. Normal in, normal out. Then after my normal in, I keep on going. That is my inspiratory reserve volume. The amount of gas that can be inhaled over and above that which is normally inhaled in quiet breathing. Okay, that would be IRV. FRC is all the expiratory stuff. Number 15, which of the following is equal to total lung capacity? Which one of these equal total lung capacity? Total lung capacity. Good. A, tidal volume, plus ERV, plus IRV, plus RV, all of it, right, is total lung capacity. All right. We already did this. This is too quick. After the most strenuous expiratory effort, gas that still remains in the lungs is called what? Good. Reserve volume. That's on there twice. All right. Now, number 17. Which of the following of these following can increase the compliance? Which one of these would increase compliance? So you got to think about compliance being increased. What does that mean for elasticity? What does that mean for different diseases? So think about that before you look at your choices. And then you look at your choice and see which one of these conditions will cause an increase in compliance. Good, Ms. Thomas. Good, Ms. Rose. Look at it again, Ms. Scott. Good, Kyla. Kayla. When we talk about an increase in compliance, guys, we're talking about COPD. If you have COPD, you're going to have an increase in compliance and have a higher FRC. So which one of those diseases are from COPD? It would be D, emphysema. The rest of those will be a low compliance. Consolidation causes a low compliance. Pulmonary edema causes a low compliance. A pneumothorax will cause a low compliance, and pulmonary fibrosis will cause a low compliance. So that would, if you know your diseases and what is what, that would have been an easy one for you. That's the only one on there that's an obstructive disease is emphysema. The rest of them are restrictive. Okay, the rest of them will cause a lower compliance. All right, another calculation. A patient has a tidal volume of 568 mLs, and they're breathing at a rate of 25 breaths per minute. What is the average minute ventilation? What is their minute ventilation? What is their minute ventilation? All right, good, Miss Rose, Thomas, Kayla. Yeah. What is the minute ventilation? Rate times frequency. I mean, frequency times tidal volume. What you got, Miss Taylor? Good, Miss Scott. Miss Taylor, you got an answer for me? All right, the answer should be A, 14.2. You do 0.568 times 25. That's the formula for minute ventilation. You get 14.2 liters. Number 19, regional factors affecting the distribution of gas in the normal lung results in which of the following? So which one of these statements is true about ventilation and the region of the lung? Good. Good. So it's B. More ventilation goes to the basis of the lung. Should be of the lung. More ventilation to the basis. Don't worry about that lung core stuff. We haven't talked about lung core, so that's just something they threw in there. But more ventilation goes to the basis. Does anybody remember how much? How much more goes to the basis as far as ventilation is concerned? How much more? Good, Kayla. Miss Rose, look at it again. You're getting it mixed up with the perfusion. I want how much goes to the basis as far as ventilation. There you go, Miss Thomas. Should be 4 times. 4 times as much more ventilation to the bases and 20 times more perfusion to the bases. Okay. All right. Last one. What is the amount of gas that can be exhaled below the resting expiratory level? So what is the amount of gas that can be exhaled? See, that can be exhaled below the resting expiratory level. Good. ERV. ERV. All right, so that was a sample type of exam. So depending on how you feel like you did on those, whatever ones you missed, that's what you need to go and study a little bit harder on, okay? Look at that one a little bit harder because you have your test tomorrow. Now, you have to also look at that wording because, like it said, number 20, what's the amount of gas that can be exhaled below the resting expiratory level? Well, we say normal out, normal exhale, quiet exhale, resting exhale. All those are the same thing. So I'm saying, so be careful with the wording. You got to know what they're talking about. Resting expiratory level is after the normal tidal volume, right? Normal out, normal in, normal out, normal in, right? That's resting or quiet and all of that. So be careful, all right? Now, last thing I want to do now is take your break first. Let's take a 15-minute break, so it's 35 after. Come back at 55, 9:55. I'm sorry, 9:50. Come back at 9:50. 9:50. I'm going to pause the recording here. We're going to come back at 9:50 and start working on the study guide. And you're going to allow you time to work on the study guide. If you have questions about it, I'm here to ask me now while you're working on it, okay? But we want to complete that study guide during class. All right, pausing the recording for a 15-minute break. At this time, I want you to work on the study guide. Here it is. Let me share my screen as classwork. Okay. Now, you're going to take a picture of this when it's done today. You're going to take a picture of this and you're going to email it to me. Matter of fact, not email, but I'm going to make this the assignment for tonight for attendance. So I'm going to put this in. I'm just going to say, do the study guide, and you're going to take a picture of it and upload it by midnight. But I want you to work on it now. That's what we're working on right now. It's classwork. So it's tonight's homework, but it's going to do it as class now. So that way, if you have questions about it, you know, we can go over it or help you out to kind of guide you in the right direction. But I want you to use your book which I think is chapter 9 and 16. I'm not sure. Look at your syllabus. But wherever chapters you've been reading every night, this is where you will find your information. Okay? Make sure you answer them in their entirety. I'm going to pause the recording while you guys are working on that, but I'll still be available if you need me. This is considered class work. Okay? We're doing this as class work. While you're doing that, I'm going to be going to the Canvas and uploading it, where it will be able for you to take a picture of it and upload it to me for your credit. Now, if you upload to me and it's like every last one of these are just little one-word answers, then I'm not going to give you credit for it. Because when you fail the exam, you're going to wonder why. Okay, I want you to look at these questions deeply, answer them completely. Okay, even if you need another piece of paper for it, don't try to stick all your answers in between these questions. Okay, so I'll let you work on this for a little while, then I'll scoot it up. We're on 1 through 8. It should take you a little minute to really answer these questions completely, and then I'll scoot it up and allow you to do the rest of them. Okay, so that's what I want you to do. All right, I have just progressed the work study guide up to number 9 through 16. All right, so you have time. If you're watching this at home later, you can fast forward through it and watch the whole thing, but it is to be turned in tonight by midnight for your attendance for today. It's this complete study guide. Okay, don't forget, no one-word answers unless it absolutely calls for a one-word answer. You need to really explain these things to me. I'm going to be looking at them tonight, okay? Because we have a test tomorrow, and if you just put anything on here and then fail the test, it's like, well, this was your opportunity to really dig deep and find this information. So I'm going to pause the recording again as you guys work on 9 through 16. All right, I just advanced it to the last one. Now it's showing number 17 as well. So I'm giving time to finish that up, and then we're going to go over some oral questions and, pretty much like a little review. That's pretty much everything. I'll use one of the PowerPoints and kind of just go back through the PowerPoint quickly after we do some of the blast from the past questions. Pause the recording again, get a little bit more time to do that. There we go. We've completed now the study guide. You guys work on that. If you didn't finish it up and turn it in by midnight tonight. That will be your attendance for tonight. Also, we're going to ask you just a few questions from the blast from the past. So if you are here, you can cut your camera on so I'll know who's here, because I'm just going to ask a few. It's just this amount right here. We'll go down the list and ask everybody a couple of questions, and then we're going to be through, okay? So if you let me see. Miss Rose, are you still with us? And Angelique?
Yes.
I'm going to go down the list and just ask a couple of questions. Start with Miss Thomas. Miss Thomas, cardiac anatomy. Where does the normal cardiac cycle stimulus begin?
The AV node or the SA node.
SA node. Okay, Kayla, pulmonary anatomy. Why does aspiration occur mostly in the right lung?
It's straighter.
Good, straighter and larger. Okay. All right. Miss Rose, pulmonary anatomy. What nerve stimulates the diaphragm?
Cranial nerve.
Nerve, okay. Angelique, pulmonary anatomy. What's the purpose of the gel layer? Are you with us, Angelique? You must have stepped away. All right. Ms. Thomas, what's the purpose of the gel layer?
To capture anything that might have gotten into the airway.
That's the sticky part of the mucus blanket that traps foreign particles. All right. Kayla, what's the formula for lung compliance? Formula for compliance.
Volume over pressure.
Yeah, it's volume over pressure, but also remember it's the change in volume over change in pressure, okay? You'll see it either way, but for this oral, make sure you tell them change in volume over change in pressure. All right. Ms. Rose, name 2 patterns used to characterize the flow of gas through the respiratory tract. 2 patterns used to characterize gas that flows through the respiratory tract. Ms. Rose, you're muted.
I'm sorry. I don't know that one.
Laminar and turbulent. Laminar and turbulent. All right. I don't think. Angelique, are you with us? All right. Ms. Thomas, pulmonary mechanics. Define tidal volume and how much is it?
How much you can, or how much gas you can take in during normal breathing, and 0.5 liters or 500 milliliters.
All right, Kayla, pulmonary mechanics. What values are needed to calculate minute ventilation?
Frequency and tidal volume.
Good. Frequency and tidal volume. All right. Ms. Rose, name the 4 types of dead space. Four types of dead space.
Anatomical,
Anatomical,
alveolar,
alveolar,
physiological, and mechanical.
all right. Ms. Thomas, pulmonary mechanics. Define vital capacity. Vital capacity, and how much is it?
I don't know.
Vital capacity is the maximum exhalation following a maximum inspiration, right? All that you can do, all the air you can breathe in and all that you can push out is your vital capacity, and it is 4.8 liters. 4.8 liters. All right. All right, Caleb, cardiac anatomy. What is sinus tachycardia?
Heart rate above 100.
Good. Heart rate above 100. All right. Miss Rose, what is the formula for Celsius? You're muted.
Is it 5/9
Okay.
times Fahrenheit minus 32?
Good. That's it. All right. Miss Thomas, tell me the segments in the left upper lobe. Segments of the left upper lobe.
Your apical posterior, your anterior, your superior lingula, and your inferior lingula.
Good. All right. Caleb, define functional residual capacity, FRC, and how much is it?
I don't know.
All right, FRC is the total of the ERV plus RV, the gas remaining in the lungs after a quiet exhalation, and it's 2.4 liters. All right, so study y'all spirogram tonight. All right. Miss Rose, what does Poiseuille's law say? Poiseuille, what does his law state?
Something about the diameter of the tubing.
Okay, so if I decrease the diameter by 1/2, what happens to the resistance? It increases. By how much? 16 times. So Poiseuille says if I decrease the diameter by 1/2, then I'm going to increase the resistance by 16 times. So if this is the diameter, right? The diameter is around. If I decrease the diameter by 1/2, right? Now you only have 1/2 of a diameter. Then now the resistance inside of here has increased by 16 times. That is Poiseuille's law. All right. Kayla, name the segments in the right lower lobe. Segments in the right lower lobe. You're muted.
Is there 5 of them?
Yeah.
Superior,
Okay.
basal,
No, just superior.
just superior. Okay, inferior basal,
No. Medial basal.
okay, superior, medial basal, lateral basal, anterior
Basal.
basal, and
Posterior basal.
okay.
All right, make sure y'all study those too. Now, don't forget that Dr. McNally's segmental bronchi video that's on there on pulmonary anatomy. I told you guys to watch it. If you watched it, he really explains the segments. He shows you a tracheobronchial tree in his hand. He turns it around and shows you a lateral and all that kind of stuff of each lobe. Okay, so that's a really good video to watch. All right, Miss Thomas, tell me the segments in the right upper lobe.
Your apical, well, dang, I would have known it if I wasn't called on.
Apical and 2 more.
I'm blanking, I don't know.
Rose, you remember?
Apical, posterior, and anterior.
Good. All right, Miss Rose, what is the normal chloride level?
95 to 105.
96 to 105, that would have been close enough. Milli equivalents per liter. Don't forget that part. All right, Kayla, what are the segments in the left lower lobe? Segments in the left lower lobe.
Superior.
Okay. Anterior medial.
Posterior.
What'd you say?
Posterior.
You got superior, anterior medial, lateral basal, posterior basal. Okay, those are the segments of the left lower lobe. All right. Ms. Thomas, what is the normal potassium? Normal potassium.
3.5 to 5 milliequivalents per liter.
All right, Miss Rose, what's the normal calcium level? Normal calcium level.
5 to 10 milliequivalents per liter. Or liters.
4.25 to 5.25 milliequivalents per liter. That's calcium. I remember we said calcium is like milk. A milk gallon of milk is about $4.25 to $5.25 a gallon. Okay, if that's one help you remember. All right, Mr. Rivers, what does TID mean?
Three times a day.
3 times a day. All right, and last question for the day. I'll go ahead and give it to you again, Mr. Rivers. Define the visceral pleura. What is the visceral pleura?
Is that the material that sticks to the lungs?
Yeah, that's the lining of the lung. The lining that is on the actual organ of the lung. All right, so we had a pretty full day, guys. We finished the lecture. We went over the study guide. I gave you a lot of time to work on that as class time today. So if you're just getting on, we're done. But you need to go back and look at this lecture when I put it in there and work on the study guide. The study guide is what's for homework. All right. It's like 17 questions and they're involved. They're not one word answers. Okay. So make sure you work on that, study that. As much as you dig into that, the better you'll be for the test. If you just put a 1-2 word answers, unless they just ask you a 1-word answer. Okay. I mean, if it's a 1-word response, then that's what you do. But if it's asking you to tell me the difference between these, try your best to do that. Okay. And what I'll do is before I take the test tomorrow morning, I'll answer any questions you have on the study guide. Okay. That's what I'll answer. If you say, okay, I didn't understand number, whatever, and then we'll explain it to you before the exam. Okay. But if you didn't do the study guide or only, if you asking me any kind of question, just ask me questions from the study guide if you have them. And then we'll make sure you're here. And then I'll give you a scrap piece of paper and allow you to write your heart's desire on it. Once you have cleared your desk, I will give you a scrap piece of paper. You can write the spirogram. You can write your formulas. So tonight you need to be memorizing that spirogram. A couple of spirogram questions you guys got stuck on and a couple of those segments. Now, you don't have the segments on this test, but you will have the spirogram and asking me to which volume is this, which capacity is that, just like the practice test we took after the lecture. Okay, so it'll be questions like that on your exam. Heavy on the spirogram, heavy on the minute ventilation, alveolar minute ventilation. If my dead space goes up, alveolar minute ventilation goes down. Okay, make sure you know the difference between shunt and dead space. We're gonna have a lot of questions like that. So be prepared, be prepared, be prepared. But make sure you're able to write that spirogram so that at least if you write it right, when you get a question, you should be able to process of elimination or whatever from your spirogram, right? That little box that you draw. The spirogram is there in the module, right? We got it. Let me show you right quick. We got it in here. There's a volumes doc that we went over yesterday in tutoring. For those that came to the tutoring, let me see. This lung volumes, no, that's the PowerPoint. Yeah, don't forget the lungs volume PowerPoint. That ain't what I'm talking about, though. The lung volumes document. Let's see. Yeah, the volumes document. It has all your stuff right here. So study that. Showing you the tidal volume, the inspiratory capacity, the IRV, ERV, FRC, all of those things there, guys. Look at this, and then not only this, but look at those sheets that I gave you, the whiteboard, right? I show you the whiteboard. Here it is right here. Damn, why does it do that? Whiteboard number 1, right? Got the box. This is what you need to be able to do. This box right here. If you can do this, it will solve so many of your problems. If you can just write that on that blank sheet of paper, it will do so many of your problems. You start with total lung capacity. Then I always do my VT first. I do my total, I make my box, and then I do my TLC right here. And then right beside it, in the middle of TLC, I put VT. Then above VT, of course, is IRV. Below VT is ERV. And then that little funny little RV is always there, okay? Then I go over to my capacities. IRV plus VT is IC. And ERV plus RV is FRC. And then I go over a little bit more. Vital capacity is everything I can do. So ERV plus VT plus IRV is all VC. And then, of course, RV is still hanging around down here. That's what you got to do. TLC, and then start with your VT. Go above and below, and then RV. Scoot over, do your little capacities and your vital capacity, and then you're done. If you have this, I promise you it'll make it so much easier, okay? Because then you can do process of elimination. If it says vital capacity minus RV is what, right? Well, then you'll be like, that only makes sense, right? Vital capacity, take away the RV, you have to know RV not even in vital capacity, right? That's not even there. So that's not even a valid question. But if you don't know that, it'll throw you off and your mind will be gone, okay? But if they say IC plus or IC minus the tidal volume is what? Well, all you gotta do is look right here. Well, inspiratory capacity. If I take away the tidal volume, then I'm left with IRV, okay? So if you can do this, I promise you it will make your day so much better. And then, of course, down here, I've got the formulas for you. Minute ventilation is frequency times tidal volume. Alveolar minute ventilation is frequency times tidal volume minus dead space. Now, you might see this F on the other side, but it doesn't matter. Multiplication is multiplication, right? You do what's in parentheses first, and then you do the multiplication. So it's still mathematically sound. They do that to throw you off, okay? So just because the F is on this side does not mean it's wrong, all right? But you know that. Everybody in here is capable. Dead space, 1 cc per pound. If they give me the weight in kilograms, I must convert it to pounds before I start talking about dead space. Tidal volume, if I'm going to estimate the tidal volume, it would be 3 cc's per pound, okay? Compliance is change. This little triangle means change. Change in volume over change in pressure. 4 types of dead space: anatomical, alveolar, physiologic, and mechanical. That's what Ms. Rose told us, right? And these are some examples up here of some addition, right? Some addition for the spirogram. All right, so that's whiteboard number 1. Then I gave you whiteboard number 2. And it's kind of like, I think this is the one with the waveform. Yeah, this has the same spirogram, but in waveform, right? In, normal out. Normal in, normal out. Normal in, and then the gas that I can move after a resting inhalation is this part. This is IRV, okay? 3.1 liters. Then if I do tidal volume plus IRV, I have inspiratory capacity, IC 3.6, right? 3.6 liters. Then everything that I can do would be ERV plus tidal volume plus IRV. And that's my vital capacity from here all the way up to here, which is 4.8 liters. And then, of course, my FRC is my ERV plus my RV. together, one is 1.2, the other one is 1.2. So that should be easy for you to remember. ERV is 1.2, RV is 1.2. So FRC is 2.4. See, FRC from here to here, which encompasses both of these, is 2.4. Okay, and then total lung capacity is 6 liters. 6 liters. Okay, so use these guys, look at them, study them, do your reading. You shouldn't have no problem. If you can write this spirogram, I'm gonna say it again, I probably think I said it 100 times. If you can write the spirogram, then you should have no problem. Okay, that will eliminate some of the answer choices right off the bat, because you're looking at it and say, well, that don't even make sense, right? And then you can choose the best answer, and then you shouldn't have no problem. We're going to knock that test out. So when you come in the morning, I'm going to let you clear your desk, and before that, I'll answer any questions you have on the study guide. Okay, you know, anything on the study guide, I will answer that question for you. After that, you'll clear your desk. I'll give out blank pieces of paper, and you may write whatever you want to write on them. Okay, I have calculators here. You cannot use your phone. As long as I can see your screen when you're taking the test, we're going to be fine. All right, easy 100. Knock this out. We're going to get into ABGs. This is the most exciting part of respiratory coming up. It's ABGs. If you can do ABGs, you will be a good therapist for the rest of your career. If you cannot do ABGs, you will not make it. Okay, that's just bottom line. It's just like saying, if you can't run, if you don't have any legs, you can't swim. Okay, simple as that. I don't know anybody who can swim with no legs. All right, and that's just being blunt. You have to have ABGs in your pocket in order to be a good therapist, because that's where the decisions are made. They lie on the acid-base chemistry. Okay, see you tomorrow. I will be loading this up as soon as I can. I've got to read to my son's school at 1 o'clock, so I should have it up before that, before 1 o'clock, so you can look at it and study, and I will see you guys tomorrow. Okay, all right, have a good day.